My topic for today is hybrid unilateral biportal endoscopic decompression, a combined approach for multilevel lumbar degenerative disorder using navigation. So, lumbar degenerative spondylolisthesis is frequently associated with an adjacent level spinal stenosis. In such a scenario, decompression and fusion has always been the standard of care historically. So, what is hybrid UBE? Hybrid UBE is one-level fusion with adjacent level decompression for two-level spinal stenosis with spondylolisthesis. So, why we do a hybrid endoscopic discectomy? So, multi-level fusion increases the biomechanical stress leading to degeneration of the adjacent segments. Limiting the length of the fusion construct and preserving the posterior elements can help to avoid the adjacent segment disease. So, the aims and objectives will be to evaluate whether unilateral biportal endoscopic fusion with adjacent segment decompression for multilevel stenosis with degenerative spondylolisthesis is a feasible treatment option. We have evaluated functional outcomes using VAS and ODI scores and radiological outcomes regarding fusion rates. It's a prospective study with 14 patients and 1 year follow-up. Inclusion criteria being age in the range of 18 to 80 years of both genders with degenerative spondylolisthesis with adjacent segment spinal stenosis with a failed conservative trial for 6 weeks. So coming to the surgical technique, initially we apply the reference frame and use the spinal needles to mark the levels. The pedicles are marked of the index vertebra where the fusion is planned in the AP and the lateral shoot. Then triangulation is done at the spinolaminar junction. So we create two channels, that is, one is the viewing portal and one is the working portal. So with the help of this instrument which is seen in the viewing portal, we can identify it in the O-arm navigation where we are accurately placed at the spinolaminar junction. So this is a targeted approach using the O-arm navigation. So we can identify the exact position where we are so that portal placement becomes easier, because endoscopic decompression is a highly targeted procedure requiring very specific location of the portals. So the navigation helps in maintaining and achieving this exact location. So this is our OT setup and this is a 3D shoot. This is the O-arm with the optical camera, that is the navigation, the TV which we see, and this is the machine. So the surgeon and the OT staff are outside the operation theatre while the spin is ongoing so that there is no radiation exposure to the surgeon as well as the staff. So in the hybrid UBE, we do the decompression at one level, followed by cage insertion at the same level. Then we go on to the next level and decompression is achieved at the adjacent level. And then at the last, the MIS pedicle screw insertion is done. The pedicle screws are inserted through the same viewing and the working portal so that we don't need to take a separate incision for the pedicle screw insertion. So coming to the technique, this is the, after the creation of the portals, we use the RF ablation because the lumbar spine doesn't have any free joint space. So we have to create space with the help of the radiofrequency ablation. This is followed by a laminotomy with the help of the Kerrison rongers, which we use in the open surgery as well. After decompression, we do the discectomy. This is at the index level where the fusion is planned. This is showing adequate decompression. After decompression, we insert the cage, and the cage after insertion can be checked in the navigation regarding the accuracy and placement, exact placement of the cage. And these are the MIS screws which are inserted. So the portal in the middle is used as a viewing portal for the fusion level, and when we move on to the next level cranially for decompression, that viewing portal changes into the working portal. So we use that same portal for both the levels. So it minimizes, it leads to minimal collateral damage, midline is spared, preservation of the facet joints, and minimal damage to the posterior spinal musculature. Post-operatively, immediate in-bed mobilization is started with static quadriceps and ankle pump exercises. Walking is commenced within 12 to 24 hours of surgery. No drain was inserted in any of these cases. Coming to the demographics, 14 patients were enrolled, out of which 10 were male, 4 were females. L3 to L5 stenosis was seen in 8 cases, whereas L4 to S1 level was seen in 6 cases. Surgical time was 104 minutes. Blood loss was around 30 ml. Average duration of hospital stay was 2.8 days. And as of now, we have not seen any complications with this hybrid UBE. VAS and ODR score was seen. So post-operatively, VAS for back and leg was significantly reduced. Coming to the discussion, the SPORT trial mentions that 35% of the patients with degenerative spondylolisthesis have multiple levels of spinal stenosis. So one of the major factors of preventing this adjacent segment disease is to prevent facet joint violation, reduce the level of the fusion construct, reduce the damage to the posterior spinal musculature. So all this can definitely be achieved with this unilateral biportal endoscopic technique. And Hamsaki in a cadaver study in 2009 mentioned that the structural strength of the motion segment can very well be preserved of more than 80% with UBE decompression. So hybrid UBE helps in alleviating the radiculopathy, reduces the instability, shortens the fusion levels, thereby reducing the risk of ASD. And with the minimal exposure, the posterior elements are left intact, which leads to improved post-op recovery and good functional outcomes. So hybrid UBE is a feasible approach for lumbar and degenerative spondylolisthesis with adjacent segment spinal stenosis. Addressing the shortest fusion level with the minimally invasive technique is the core value of this procedure. Limitations of this study is a small sample size, primarily due to the strict case selection and a short follow-up period of 1 year. This is a case of 54-year-old male with low back pain and left lower mediation with significantly reduced standing and walking tolerance. Had grade 1 listhesis at L4-5 with stenosis at the adjacent level. This was his MRI. Postoperative X-ray showing fusion at this level with adjacent segment decompression.